All right, looks like the participants have slowed down. So thanks, guys. Thanks for joining our panel today. The panel is entitled COVID-19 and Beyond, a Pair's Experience on Virtual Care During the Pandemic. We're really excited to have Dr. Lopez here today to share what Cigna has seen during the current public health emergency. And if anyone has their phone on, I can kind of hear some background noise. So if they could just mute that, that would be great. Just kidding, guys. We can't hear you, but now that I got your attention, let's keep going. I'm Kandice, and I work in state government affairs for Cigna. And with me is Dr. William Lopez, who's our senior medical director at Cigna. And as background, Dr. Lopez oversees the medical director team responsible for medical necessity reviews, case management, and claims activity. Dr. Lopez provides clinical expertise to Cigna's sales and marketing teams during client and stakeholder meetings. Additional areas of focus for him include the integration of behavioral health services, collaboration into accountable care programs, and the implementation of Cigna's national telehealth strategy. Dr. Lopez truly is a leader in Cigna's response to the opioid epidemic, and he's been thoroughly committed to driving solutions there. Prior to joining Cigna in 2006, Dr. Lopez was a staff psychiatrist and medical director for psychiatric services at Snowden in Fredericksburg, Virginia. Dr. Lopez was also a captain in the U.S. Air Force, where he practiced aerospace medicine. If that wasn't all enough, y'all, Dr. Lopez is a badass veteran, operations in Desert Shield and Desert Storm, and he's passionate about supporting and leading veteran-related initiatives, which has been a real focus for Cigna in relations to telehealth targeting, really gaining access for veterans. Dr. Lopez lives in Asheville, North Carolina with his wife and his daughter. She's a freshman at North Carolina State. And he really enjoys outdoor activities, hiking and whitewater rafting, which are perfect during times of COVID when it's hard to get anywhere for too long. So I'm going to turn it over to Dr. Lopez. He is sharing his screen. You all should have the slides up on your screen, and we'll kick it off.
Thank you, Kandice, and thank you all for the opportunity to share our experience here today with you. As Kandice mentioned, I live in Asheville, North Carolina, and I also have been impacted in some ways with COVID, especially with my freshman student. Actually, she's at home doing online work. So we are not quite empty nesters yet, and we're working on it. Hopefully we'll get her back to campus soon, but just sharing that as one small way in which COVID has impacted all our lives. We move to the next slide. During the presentation today, I want to cover just three main areas, just kind of review our new virtual environment. Where are we now with after COVID with telehealth? How has that impacted providers? And get a sense of how they perceive the pandemic and how have they responded, and what is their view of the future. I'm going to spend a lot of the time during the presentation today sharing our intel or our understanding of the provider's experience. And at the end, I'm going to share with you what we have seen in way of claims, activity, utilization patterns, and what are the things that we're looking forward toward the future to see how we can position ourselves for eventually a time where we have more of a normal environment post-COVID. So, if we have been, or if I have been presenting a talk on telehealth before March, I may have used this slide. And I thought I was going to pull it out, but I said, well, I may use it anyway. And this is why. I mean, these are some of the forces that have been driving changes in the healthcare environment. And they may have been the tailwinds for telehealth to get more, better implemented, better for a better pickup, like for example, the decreased availability of providers, decreased time, increased technology accessibility, high cost of care, and the increased knowledge of our customers or patients related to the access to technology and telehealth. However, even with all this influence, we were just seeing maybe 1%, 2% utilization of virtual services within Cigna. So really not a big uptake. However, it took a pandemic for really see a change, and this is where we are now. COVID had been like the fuel to the fire, really has accelerated adoption of virtual healthcare. With expanded coverage of virtual services, currently Cigna is covering pretty much all CPT codes are in our providers' fee schedule. And we're reimbursing 100% of face-to-face visit, where prior to COVID, some payers were paying around 80% to 100, and CMS also was not paying 100%. We have had open door relating to platforms, FaceTime, and other Zoom, so we have more access to platforms that customers can use or patients can use to access telehealth. We have waived co-shares or reduced co-shares. CMS has been very active, loosening up some of the regulations that govern the use of telehealth, where it used to be mainly for geo-remote areas and for specific intent. And also, we have seen the states loosening up the regulations that govern their application of telehealth and the practice of providers between state lines. So that really has helped in regards to accelerating the implementation of telehealth. So first of all, I'm gonna share with you what we have learned from our providers. What we have done earlier this year, we had a survey that we sent to a number of our providers, and the information I'm sharing today is from two different surveys. The first one was in mid-May, and then we had another one mid-July, trying to get a sense of how they perceive the pandemic in regards to their practices, how they felt that they were able to recover from that post-COVID, the changes that they may have had to make, and how they have adapted with the use of technology. So just want to make sure that as I'm talking, you're going to hear me refer to wave 1 and wave 2. Those are the two surveys. Wave 1 was again in mid-May. Wave 2 was in mid-July. Some kind of background on this study. I think this is mainly related to wave 1. That's wave 2, the second study. The group for the first study was the first survey was very similar, but in general, we had 401 healthcare providers that range in sizes and geography throughout the United States. We had some requirements just to make it a consistent experience for the survey purposes. They have to be practices that were based, brick and mortar, kind of based on office and clinical setting. At least 50% of their reimbursement was through commercial payers. And they were using, during COVID, at least one type of virtual capability, being video or telephonic. And you can see the spread between specialists and generalists, pre-even distribute. If we break it down to a different view of the group's size, and again, kind of all different group sizes to kind of account for the variety of practices that we see in our network. So in summary, I mean, just to give you an overall summary, and then we'll go more in details as we go along in the interview. For most prescribers, when you look at their the initial response that we got during wave 1 and wave 2, wave 1, a significant number of providers thought that this will be resolved for long term, but higher number thought about that way in wave 2 of the second survey. They went from 63% to 74% of providers that realized or thought that this is going to be a long-term solution instead of something that will be resolved within a few months. But even with that, I mean, many providers were optimistic and thought that they will be able to resume full practice post-COVID within a few months. Telephonic and video were the most common modalities for use of virtual care. There was also significant use of remote monitoring, and again, I will share more in detail about that modality as well. About 80% of providers were not offering any kind of virtual care prior to COVID. And for a number of reasons, some of them because of technology, others were related to reimbursement. So that was a significant number of providers, I mean, from our perspective. There was an initial positioning from providers of having a virtual first visit. This initially, during the first survey, about 60% of providers, 56%, had a virtual first visit policy, and that had decreased to 29% during the second survey. And then so you can see also the wave 2 physicians were less concerned with the additional costs of implementing telehealth and how that will impact their future negotiations related to contracting. So kind of comparing the two surveys and how attitudes change through time. As you can see here, again, there was a shift toward a sense that it will take longer to resolve the issues around the pandemic and get a more stable environment. Went from 63 to 74%. And this actually interesting how they perceive they're going to function and how many of them were going to recover to pre-COVID levels. So from our survey, about 84% of provider groups felt like they will be able to resume or get to normal capacity levels post-COVID. 16% felt that they would not be able to recover. However, and I'll show that in the next slide, from that 16%, up to 80% felt that they will get between 70 and 90% of their volumes back. So they were not feeling they will be able to recover everything, but they were optimistic that they will have some recovery. And the pattern that we have seen through the survey answers has been more positive view of their practice future from the first survey to moving to the second survey. Relating to staffing, as you can see here, practices had to reduce staff. About 43% of the practices that we surveyed did reduce staff. Fortunately, a large majority of them have brought back some of their staff in their practices. Usually, some of them fully, but most of them have brought some of the staff back. There was a small percentage that they were not bringing anyone back, even during the second survey. So I gave you a kind of an overall view of their practice perception of COVID and the impact to the practice. Now, I'm going to move on to talking about how they approach virtual care and telehealth in their practices. As I mentioned at the beginning, telephonic and video remains the main modalities that were used for the telehealth. So there was not a lot of responses related to texting, emails, and such. You can see here the breakdown relating to practices type from generalist to specialist and practice size. Pretty consistent overall. So from video and telephonic, video definitely was the preferred method or the most used method, and it was 54% over 34% for telephonic. And you can see the breakdown as well. I think it's consistent again among all the practices relating to specialist versus generalist in the use of these different modalities. For remote monitoring, a couple interesting factors. Generalists or primary care providers at large utilized remote monitoring more than specialists, specifically around hypertension, diabetes monitoring, and such. However, specialists had niche areas where they were more found to use remote monitoring more. The two examples here are, one of them was the gestational diabetes, as you can see there. So in general, the PCPs or primary care providers took advantage more of remote monitoring that specialists based on our survey. Looking at the future, a little over half of providers stated that they're going to have some plans to invest in technology that is HIPAA compliant. So I think that there's a sense that some of the lax rules that we have here or now relating to the type of technology are probably going to be rolled back. So they're already thinking about how they're going to invest and to what extent they see this as a priority. So, and some, I mean, like about 30% felt like they did not need to have any further investment. Apparently, they probably had already some technology in place that they feel comfortable with. And we didn't see any significant changes between the initial survey and the follow-up survey. So I don't think it's a surprise. Prior to COVID, about 80% of practices did not offer any type of virtual care to patients. And those that did, they had only offered for about 10% of their visits. They were virtual. And okay, let's see the next one. So in this slide, we're kind of trying to break down the virtual visits a little bit more. Hold on, let me just go back and make sure I didn't skip one. Sorry. So this slide basically is just sharing with us that at large provider groups are feeling like they want to continue maintain some presence of virtual visit post-COVID. And that's probably going to be a technology or a modality that will continue. This is not clear, I don't think, to anyone, that, to what extent that's going to be. Anecdotally, from the conversation that I have had with some different groups across the nation, during the height of COVID, there was, significant utilization. Some groups like Scripps in San Diego, they were having about 3,000 virtual visits per day. New York Presbyterian was having between 30 and 35,000 visits per week. Summit Med Health in the New York area also had like 90% of their visits that were virtual at that point. Some of these numbers have been going down. I know, like from conversation with Summit, they're going back to around 20% now. So they have going back to more of a pre-COVID level. And I think that in general, what the sense is that at the end of the day, after the emergency period is over, we will land somewhere between 20 and 40% utilization of virtual, probably closer to 20%. But still a lot more than the 1% or 0.5% that we saw prior to the emergency period. So, and it kind of reinforced what we were just talking about, that they plan to continue virtual visits post-COVID. So. So relating to adoption of virtual first policy, that's something that shifted. I think that we saw more of it early on during the first few months of the pandemic. Now groups are moving away from that, requiring a virtual first visit, providing more flexibility for her patients, and also realizing that things are moving to a place where they can start bringing back office volume back to their brick and mortar offices. So relating to the type of visits that they were practicing at large, the most frequent ones were check-ins or routine visits. Most of them were for a visit prior to renewing a medication prescription or for management of chronic conditions. Then after that, you see how things tend to drop a little bit, and you have some triage calls, diagnosis and treatment for acute conditions like minor medical conditions, the flu, rashes, sore throat, things like that. Interestingly, like in total, about 40% were for new patient visits, which is a significant number. And also, we have seen a lot of utilization for urgent care. That's another area that we saw a change from pre-COVID related to virtual visits. I'm going to talk a little more in detail related to behavioral health in the next few slides, because that's another area where we saw, so we try to get some of our providers' sentiment related to virtual. Relating to the length of the visit, I think from this slide, what you can take away is that at the end of the day, providers, in average, feel like they took as much time as a face-to-face visit for a virtual visit. So some of them thought it was, had a sense it was less, some of them more, but if you average everything out, probably around the same time for most providers. Staffing, again, that's an area where there was a lot of challenges. Providers have to adjust to the different environment related to virtual care. And the challenge has been that even though a lot of their volume went to virtual, they still had to maintain brick and mortar presence. I mean, they still have a building to pay rent for, staff, and equipment, and still have a volume of patients that will show up to their offices. So it's a fine balance for them to try to maintain both delivery of care models and the staffing associated with that. Okay, so we'll move to behavioral health briefly. Want to make sure we have enough time for questions. So this is the perspective of primary care providers and specialists, medical, not from the perspective of the behavioral health provider. So this is how, what the sentiment is relating to their patients' need for behavioral health services. And as expected, and as we many thought about, there was an increase on their perception of the need for behavioral health services during the pandemic. And as the time progressed, this decreased. So at the peak of during the survey in May, there was a sense that there was a significant number of customers that needed behavioral services, and that went down a little bit as the time went on. So again, I mean, now the second wave of the survey, less physicians expect the same high volume of behavioral patient need services following the pandemic. All right, so a little switch here from clinical more to their perspective relating to contracting. Just one slide on this topic here. So basically, for providers, there was a sense that there's going to be some impact to their workflows, their procedures, their staffing levels, investment in equipment that they may need to take into account when they're renegotiating contracts, and that was higher on the first wave than on the second wave. So as time went on, and provider groups felt like there's things, things are working out to some extent. I'm bringing back some volume. I may be able, I will be able to survive. They felt a decreased need on having to think about renegotiating contracts. Okay, so now switching gears, we're going to talk about what we saw. We heard from the providers of what the experience was. Now what we see in way of claims, activity, and what we think about in the future. So again, no surprise here. Actually, total from the beginning of the year through the height of the pandemic, we saw about a 9,000% increase in virtual care. That's no news there. And I'm sorry for the kind of compressed slide here, just trying to get a lot of information to give you the full picture. But you can see the beginning of the year, February, and then, of course, in March, things kind of picked up and had been maintaining. And then as things have somewhat decreased in some areas, you see ups and downs on the number of claims that we receive. This is basically the geographic distribution where we see most of our claims. Again, like Texas, California, Tri-State, New York, Florida, some of the major states. The darker, the higher the volume of the claims that we're seeing. If you break them down for counties, kind of just actually the only thing I can mention just that one dark blue there, that Maricopa County, which is the largest county in the United States. So then you see like Orange County in LA and San Diego County also standing out. And if we had we could probably enlarge these, we could see New York also popping out. And what kind of claims did we see? So at large, E&M codes, 95% were E&M codes. The main difference that we have seen is some movement when you compare face-to-face to virtual visit, movement from like 99212 to 99214 or 99213 to 99215. So a little shift on the higher complexity. And we still trying to analyze that and try to make sense of it, but that's one of the things that we have seen related to utilization of different services. Diagnosis is, if you look at specific diagnosis, you have here like hypertension was double the list, acute respiratory infection, a cough, and others. Low back pain is up there. Now, if we bunch it in diagnostic groups, then it looks a little different. Like musculoskeletal jumps to the top of the list, followed by ENT and general medical diagnosis. So kind of give you a sense of what kind of conditions have been mostly managed through the use of telehealth. One of the areas that we were exploring too was how are our provider groups being impacted by virtual? Are they suffering from the lack of ability to order ancillary services like labs or x-rays? So we looked at that. So we looked at the volume of virtual visits and compared that with charges for ancillary services throughout this time period. And our hypothesis was that, well, they're going to be seen virtual, so we probably would not see as many labs done. And if they're ordered because they really need it, or they really need that x-ray instead of just, let's do a CBC just to see how you're doing. So, so actually we found out that was not the case. There was indeed a decrease in number of lab orders, but it was linearly related to the decreased volume. So there was not really a big differentiation there. So what is still not clear, and we have to look deeper into is, are this patient going to national, like a LabCorp or Quest, or are they going back to the doctor's office where, that could still be an impact to the provider if they were able to do labs pre-COVID. Now they still need to get the labs, but they need to send the patient somewhere else so they don't get that benefit from that source of revenue. but as you know, so far the data that we have, this has not been a significant impact aside from the overall decreased volume of visits. So where are we now? I mean, where are we looking into the future? There's a lot of uncertainty. We have to see how much of this sticks. I mean, I believe that a lot of patients are going to like using virtual. They're going to continue using it, where they may have not even considered that before the pandemic. So we have to see what the consumer demand and adoption trends are, what is going to be the coverage, and how can we make sure that we cover things that are actually doable through virtual, evidence-based. Are we going to see changes on benefit designs? Are clients going to ask to mix things up to make it a better environment for their employees? Levels of reimbursement. Prior to COVID, many payers were around 80% of face-to-face. Some of them were 100%. So what is going to happen? I mean, we're being reimbursing 100% visits now during COVID. Are we going to be able to go back? That's still undetermined. We haven't heard from CMS on long-term recommendation. There's some signs that they may make some changes, but we don't really have a clear declaration. What are the providers are doing related to the platforms they're going to use? And again, also dependent on what CMS does after the emergency period. Are they going to continue to allow non-secure technologies, which from the indication I have, that probably would not be the case? And how many of the regulations or changes that they made are going to continue post-COVID? And from a payer perspective, at least from Cigna, what we're looking for, and we would like to see some consistency or regulatory consistency, that things are applied across the board in a consistent manner. We also have to see, and there's uncertainty about what states are going to do with the changes they made during this pandemic. So again, a lot that we still need to learn. And for the next few months, these are the areas that we're probably going to keep our eyes on. How are, what other payers are doing, what you all are doing out there, what are you going to do after COVID, what CMS is going to do, what are clients' expectations, what do they want for their employees, customers' expectations, what are the trends that we will see relating to reimbursement. We have had a handful of payers nationwide that have take positions about reimbursing 100% or not. So, but nothing at a national level that we have, I'm aware of at this point. We need to learn a lot about outcomes. How is virtual compared to face-to-face? Outcomes both clinically and also related to the impact and cost of care. Is virtual really going to offer lower costs and higher efficiencies? And what is going to be, what we're going to see related to the provider behaviors related to virtual, and how are they going to adapt, and what changes they will make to continue in a virtual environment. At the end of the day, from our perspective, these are the areas that we're going to be focusing in the future. Coverage and reimbursement, design of new products or products that align to the clients and customer needs or patient needs, how we enable our provider networks, how we complement networks with vendors, and how we exchange data between providers, and also engaging our customers, how we engage them to enable them to take advantage of virtual alternatives. That's my last slide, so I'll stop there, and we have a few minutes for any questions that we may have on the chat, or I'll be glad to answer.
Yeah, Dr. Lopez, that was excellent. We have a lot of good questions, so I'm going to fire them off as they come in. Okay, the first one, and you're super familiar with this, it says, given there is precedence with the VA system where the licensure requirement for physicians is to have unrestricted license from any state board exam, national, as well as clinical practice guidelines, should that be a policy consideration that moving to a more national medical license and just kind of just in the ability to facilitate telehealth anywhere in the nation?
Yes, excellent. Thank you for that question. The Veteran Administration has been the pioneer on telehealth. They have been doing this since the 1980s, not before. And they're way ahead of us in many ways, including licensing. So that would be something that I will definitely favor. The challenges are related to the multiple stakeholders that are involved in making such a decision, including state regulators, medical boards at different state levels, national, federal administration. So, and getting to a point where people feel comfortable letting go of some of their jurisdiction. You know, you will have to have the medical boards of different states allowing or agreeing to kind of let go of some of the controls they have for the practice of medicine in their own states. But yes, I think that will be a goal to shoot for.
Great. Next question. Were ergonomic assessments / equipment options covered through insurance claim if so many number of visits were attributed to back or pain diagnostics due to increased number of hours behind the computer for remote work? So now that we're in these kind of work from home situations, did any of that analysis go in about where we're seeing that low back pain and other symptoms come from?
Yes, you know, I don't have data on that. I cannot really comment on that. I will have to take this one away and get back. If you can get the name of the person who submitted the question, I can follow up with that.
Sounds good. So in your opinion, Dr. Lopez, where are we on the sophistication of telehealth? So have we just gotten to the tip of the iceberg? Are we, you know, like Amazon going the way down? I mean, how sophisticated right now do you think we are?
Yes, I think that let me say that we are the tipping point and past the tipping point on adoption and embracing telehealth. I think we got to a point because of the pandemic that now we're using it. We had no option. Relating to technology, I think that we have adequate technology to support virtual care right now. There may be some enhancements that could happen or could be done. I think that in 3-5 years, telehealth is going to be a commodity. It's going to be something that we will not be talking about. But what I will keep my eyes on, it will be in artificial intelligence. That will be the next big wave of technology that we really need to keep our eyes. And mentioning that, and you mentioned too, looking at what companies like Amazon are going to do. Those are going to be the big players in the next few years.
So 2 questions. So these are kind of almost on the patient side a little bit. One is, are we seeing carriers in the marketplace or providers charging for scheduled telehealth visits that end up being canceled for whatever reason?
I think that the experience, like when you think about a telehealth visit, it's nothing different than a face-to-face in regards to the service. You're providing a routine 99212 or whatever the CPT code is. This is just a difference in the delivery of care. If you do it through video. When you do a virtual visit, you're probably going to have the same experience. However, with virtual, you have the opportunity to, if you have your patient's cell phone number, you can text the patient, hey, I'm here waiting for you, are you going to log in? So there's a potential, if done right, to decrease no-shows.
I think that's right. And then, Dr. Lopez, is there, in your opinion, what are the best practices for being a telehealth patient? I have experience here because I was on the phone with an infectious disease specialist, my mom, and she asked me twice what medical school I'd gone to and what my practice area was because I think I was overwhelming her with questions. So just in your opinion, are there just good basic practices for being good telehealth patients?
Yes. First of all, let's take a step back for that question. If you are doing telehealth with a provider that you already have a pre-existing relationship, that's not so much of an issue. You should not have to struggle with that. The main issue there will be just having the appropriate technology to connect to your provider. However, if it's a new encounter, someone that you have not met before, again, you'll do the same as you would do on a routine visit. I mean, if you feel compelled in getting some background about training, that's appropriate. I think that the most important thing to keep in mind, you have as a patient the same expectation on that provider than as a face-to-face. You know, they should be able to listen to you, provide you feedback, provide you treatment recommendations, and go over all the things that they should be doing on a face-to-face. So you just make sure they don't cut corners. I mean, and I think that overall, from what we saw, providers feel like they're, at least time-wise, in average, it takes as much as a face-to-face. So my sense is that they're doing as much work too.
You make me feel better. That's great.
Yeah.
Okay, guys, we're at the end of our time. So let me promote. Thank you so much, Dr. Lopez. That was really great. Guys, next panel scheduled to begin at 12:20. Don't drop off because I hear there's a prize for everybody that stays till the end. So it's gonna be a discussion around what barriers still exist for providers and payers in delivering telemedicine, and to kind of see what the future holds. So same as before, guys, you can join the conference by going to the link for that specific panel. We're gonna sign off, but thank you, everybody.
Thank you all. Bye.
Bye-bye.